We're going to begin with session number 1, which was called Perspectives on the UME-GME Continuum. And this morning's session will provide the opportunity to hear from education leaders of our major medical associations. If you look in the brochures, you'll see their talks have no titles. That's because they were asked to answer one question. What change do you and your medical organization that you represent expect to see in the UME-GME continuum over the next decade? Please refer to your folders for the impressive biographies of our speakers because I only plan on introducing them by name and their affiliation. So our first speaker, Dr. Susan Skochelak, the Group Vice President of Medical Education from the American Medical Association.
Great. Good morning. Thank you, Joan and Steve, for inviting me to come and speak. I was worried when we said we had to be profound. You didn't say that before, so wish me luck here. It's really a pleasure to have the opportunity to talk with you about this important topic. So, I'd like to talk about the current pain points that we're experiencing as we think about the UME-GME continuum. To speak about some lessons learned from the consortium that we have sponsored at the AMA of 32 schools starting in 2013, and how some of those lessons learned will apply directly to the continuum moving into GME. And finally, talk about the vision for a decade from now. You could probably come up with a similar list to the one that I developed in thinking about this topic. The first is to call out the fact that while we're moving importantly into competency-based education, we are terribly mismatched right now. We're making our faculty, our students, and our trainees crazy by using ACGME core competencies, AAMC's EPAs, and ACGME milestones. And the first thing our 11 schools had to do in 2013 individually was map out those competencies and milestones against each other. That's on us as national leaders, and we ought to have a dialogue and fix that before the next decade. We really need to address trustworthy assessment for the handoffs in transitions in education. If you talk to the program directors, they disappointingly will still say they don't have faith in the MSPE, and that's why they continue to rely on the hard data of the NBME STEP exams, whether we like it or not, for screening as they select their candidates. We also have inflexible policies for entry into residency. That's why Dean Grossman talked about the fact that the students at NYU in the accelerated program are entering into NYU's residency programs. That's probably true for every program around if you're really trying to follow the guidelines that are set by residency matching and residency programs. We can change that, and we need to. And the July effect, this one-time opportunity for students to transition into residence, is a safety issue that we tend to be quite silent about. In fact, we've even done studies to try and minimize and say, well, it's probably not as bad as we think it is. But do you think any hospital would want to onboard every single one of their OR techs only once a year and have them all be new at the same time? It's a little bit silly when it comes to patient safety. We also do a disservice to our learners by not telling the residency program directors what we know about their strengths and their weaknesses. And on the reception of the handoff, we don't do any planning to assess where they're at, and can we individualize their residency schedule so that we could plan in the first 6 months to train them in the areas that they need the most attention. We've already heard in brief comments about the escalating time and cost that is coming for the selection process, and that's being driven in part by the perceived and or real competition for decreasing numbers of slots compared to the amount of graduates that are coming through the pipeline. And perhaps this group won't talk about it as much today, but it's important for us to think about this drop-off at the end of residency. And I know ACGME has done a lot of thinking about this. It really hit me when I read an article by Crossan et al. In Health Affairs, where at Kaiser Permanente, the medical directors assess the readiness for practice of their own residency graduates coming into their home departments. And they pointed out the example of OBGYN, where in OBGYN, the opportunity now to train in the most complicated parts of procedures that usually require open laparotomy tend to be few and far between compared to the laparoscopic procedures that the residents are training with. So what's the answer? Extend OBGYN residency program to 7 years? No, but what's the right way in which the drop-off doesn't occur so that as a residency program director, you can graduate your resident knowing that there will be an opportunity for post-residency training and let them go on and do independent practice in all the ways that they're competent for. So when we started our work with medical schools in 2013, we had 4 goals. We wanted to support the newly developing competency-based movement and really try and see if we could let there be more flexibility in the pathways through UME. We wanted to support exemplary methods of teaching in the core areas that were being underrepresented and had been reported widely in the literature. We wanted to be sure that the students had a good basic understanding of the healthcare system and healthcare financing and to support an optimal learning environment. The vision was to see whether the competency movement would allow for some semi-permeable transitions, since for the moment, many of our students are entering medical school with life experiences, graduate experiences, and the example I always like to give is the folks like the nurses and the physical therapists in our medical school curricula that are coming back to now become physicians. And having them go through a 4-year or even a 3-year program doesn't necessarily make sense. They can accelerate that program, and you are working on how to do that with lots of folks coming forward. Residency, again, the next frontier. Is there a fixed time in residency, or now that we have milestones and competency assessment, can we start to look at more flexible transition through residency? And then finally thinking a little bit differently about the ongoing lifelong learning, the CME community, and the needs of the different types of physicians that are going forward. Now, coming from the AMA ACE Consortium has been some marvelous work. Many people in this room have been part of our colleagues that we work with regularly. And in terms of the flexible, individualized learning pathways, a number of aspects of that have already been teased out as important. So we need to understand how to develop adaptive learners. How do you help someone understand what they know and what they don't know? Teach them how to regularly assess their gaps and then put into place the planning to close those gaps. In order to do that, we have to have improved assessment and feedback loops, and we really need to have a learner data management system that allows the learner and the faculty to know where they're at in their trajectory of learning the competencies that we've identified as important. There's been a lot of work on really helping faculty to know how to be a coach for teaching a master adaptive learner, helping them develop, and it's a different skill set than many of our faculty have been trained with. Finally, again, for the flexibility, we have to look at those breakpoints right now that are keeping us in boxes that don't allow us to move forward. In terms of our second goal, the integration of medical education and healthcare systems, we've had marvelous opportunities to see what the contributions of the health system leaders have been to medical education. And in fact, the overlapping circles that I have on the slide, which probably in the back you can't read, so let me read them for you, although I see you have a little side area over there to look at the slides as well. But we have added to basic and clinical science the discipline of health system science. And that emerged as people talked about the fact that if you take and look at all of the areas in the old ACGME domains of systems-based practice, practice-based improvement, communication skills, that they fit nicely together into an important and missing element of a three-legged stool. Many of the schools have invited their health system leaders to the table, such as UC Davis and Penn State, and really found that through doing that, they've been able to develop value-added roles for medical students and faculty that allows the health system to be enthusiastic supporters of the kinds of education that we're trying to start up. Specifically in terms of health system science, we've developed a textbook for medical students, nursing students, health profession students through the consortium, and I'm pleased to say that the authors of this textbook have turned their royalties over and back to the education consortium to reinvest in innovation in medical education. What's listed on the left side of the slide is more than half a dozen now articles in our medical education literature about health system science. So if you'd like to know more about how did the domains develop and what's included, you can find it in academic medicine and other places. And on the right is an example of an NBME subject exam, which we've developed in partnership with the consortium schools and the NBME on health system science to help either do formative or summative assessment in this important area. Now, excitingly, a number of residency programs have indicated that they are also interested in this content area in the textbook. And we've even had the Dental Education Association determine that they wanted to have all of their schools take a look at this content as well. I think we're onto something. The schools have been doing great work in developing technology for learning and assessment. Medical education, I think, is quite far behind in the way in which we could use technology, partly because we're in institutions where the learning technology has been developed mainly for the undergraduate enterprise, which doesn't have the same kinds of needs and flexibilities that we deal with. So across the continuum, we've had Indiana University and the Regenstrief Institute develop a platform for teaching within an EMR all of the clinical skills and decision-making that you need to use as you learn to be a physician. And they have partnered with now 6 other schools by the end of the year that will be using this teaching EMR to develop clinical skills. You, I hope, will recognize Mark Triola in one of these slides here, the opportunity to teach students about the importance of big data and how you can use big data has been very much of interest to all of the schools and others outside of in the health system. My favorite example from Mark was learning for example, how to use this web-based tool in healthcare by the numbers by just going and playing with it and asking questions, which is what they do in the course. And so when I talk to reporters about what's new, I talk to them about the example of, well, what's the most common diagnosis for an adult to be hospitalized in the state of New York? And of course, the database that's being used for healthcare by the numbers is the Sparks database, which has all the hospitalizations and other associated data for the state of New York. And so, you know, everybody's guessing really good things like, oh, it's probably a heart attack or maybe pneumonia. Well, the answer is it's to deliver a baby. Normal spontaneous vaginal delivery is the most common diagnosis, and you can go to the website and play with that and find out. But what really gets the reporters is when you start to say, you know, you can look at costs there and you can look at outcomes. What do you think it costs to deliver a baby? Well, in the rural counties, it costs about $3,000. And in Manhattan, it costs more than $20,000. That catches their attention. But it also catches our students' attention to say, wow, what's going on here? And what could be the difference? Are there outcome changes? Are there patterns of delivery that we need to look at? So the other two examples, the READY system and the VSAR system at Oregon Health Sciences University and Vanderbilt, are the envy of many schools in terms of their ability to do learner assessment, dashboarding, and tracking the kinds of information that you need to really implement a competency-based system. So together, these schools, all doing different projects, 32 of them, have clustered around areas that need to be part of our next decade in medical education for the medical school of the future. These include addressing physician workforce, technology, as previously mentioned, and competency assessment. These together form what I think becomes elements that every school will be looking at and determining how they will want to move forward for the next decade. How does that then apply to the vision of the continuum of UME and GME? Well, if you think about where we'd like to be, we would wish for flexible and seamless pathways for our learners and our trainees that really allow for adaptive learning opportunities, where we have measurable competencies and we can document through trustworthy assessments that those competencies have been achieved at the milestones along the way, that we provide safe and reliable transitions from residency into practice. And by doing so, I can guarantee you will enhance our trainee and student well-being and sense of accomplishment, that our learners are valued by our healthcare system, and that they're well integrated in the workplace, within teams and across work sites. Now, what will it take to bridge the continuum? Again, I'm going to come back to the idea that across the continuum, we have to have an agreed upon language and pathway. That needs to be an early job for all of us to get into alignment. We need to continue to improve our workplace assessments so that they're reliable, and we can define for ourselves as learners and trainees, and for others as we try to describe to them, whether it's a residency program director or a hospital administrator as you're moving on through your career, what your skill set is and where you need to continue to grow. We need to consider seriously flexibility and transition to residency at multiple points, because a 3-year program is always still going to have students that come out at 3.5 years. And a 4-year program will do the same at 4.5 years. And as importantly, how about the ones that can finish in 2 years? Wouldn't that be marvelous? Finally, we need a better way to communicate across the bridge, and that includes our accreditation organization. Let me close then by saying, how operationally can we move to that vision in 2027? We need the technology. We need some kind of learning portfolio data system that can follow the trainee throughout our lives. We need to address new selection methods that really match with what we're trying to do in competency-based and flexible training. And it's exciting to see some of the ideas and experiments that are coming forward even now. I hope, Allison, you'll talk a little bit about the emergency medicine one. We need to have stable pools of training sites, and Dr. Grossman actually mentioned one that we're considering, which is whether or not there might be, as a pilot, an opportunity for consortia to come together for stable pools of training sites where people know and trust and respect at the handoff level, and also the opportunity for lifelong assessment strategies. Specifically, as AMA goes forward, and next year at 2018, we will celebrate the fact that we'll have finished our 5-year pilots with all of the schools in our consortium. We would like to support the work that comes forward in the bridging of the UME and GME continuum. We're going to need to find places that are willing to experiment and do pilot projects. We need to have willing partners. Many of you are in the room at the National Association levels. We'll need to invest in faculty and data and platforms, and we'll need the resources for innovation so that schools like NYU and others in the room don't have to look at that loss of tuition dollars and say, I don't know where our margin is going to come from to make the changes that we're hoping for. So at the AMA, we're looking forward for our next 5-year investment in 2018 and beyond, and very excited to work with you all on how to develop these new visions and new pilot projects on the UME-GME continuum. I thank you very much.